I think this technology is one that represents the field of Barrett's and esophageal cancer and the booming nature in this area right now in terms of innovation and development of new technology when we start talking about screening and surveillance. So I think this couldn't be more right for the time. And I think as we get more back into practice after the pandemic here, and we're seeing more patients on a regular basis as we have been, this becomes even more pertinent in terms of applying some of these technologies that have made some impact from an evidence side. The reason why this has become so prevalent in the literature, and I'll talk about that one second, is the evidence. And when a technology goes about it the right way and does the correct and spends the time and innovates in the correct set of studies, it's really evident, and it's marked by reaching important documents such as guidelines.
Thanks for inviting me to share my perspective on a technology that I have been researching in great depth for several years now, and have been using really every day in my practice to improve the ability to take care of my patients with suspected or known Barrett's esophagus. So here you can see a brief summary of all of the trials looking at the detection of Barrett's of any kind to looking at the detection of dysplasia, and then in that enriched cohort on the right-hand side. And with time and experience and improvement of the technology, there's clearly been a major uptick in terms of the detection, the augmented yield, from very important and impressive numbers to start with to now really astronomically high numbers. And now with over 17,000 patients in the published literature, it's not a surprise that the ASGE, the AFS, and SAGES all went into incorporating this technology into their management guidelines. This is yet another way that by finding crypt dysplasia, something you really see by far better on WATS3D than any other modality, is something that allows you to, again, be able to risk stratify and manage your patient even better than with forceps biopsies alone. What you can see here is across the board, whether the diagnosis on the WATS was non-dysplastic Barrett's, low-grade or high-grade dysplasia, that across the board, nearly 97% of the patients, the finding on WATS affected management of the patient. You can see here that across the board, there were significant changes as a result of the WATS3D finding. And so I would make the argument that yes, in my own practice, the finding of low-grade dysplasia absolutely changes the whole plan of care for the patient, even if the forceps biopsy does not show that the low-grade dysplasia is present or even that Barrett's is present. Because I believe, based on what I see with the technology and all the data that's in the literature to date, that this is a real entity that you're finding, and it should indeed help you to manage that patient differently. I just think that we all need to start realizing and go back and look at those numbers in the published literature. The brush picks up more than the forceps. And so anybody who thinks that the gold standard should remain forceps monotherapy is really living in old times. And there's just too much data out there to say, maybe in a case or two here or there, I'm going to use a WATS. That time has passed. It's time to add the WATS3D, and now there's just too much data out there. And I think very soon the wave is going to move towards recognizing what these studies have already shown, which is that the better technique is the WATS, and the forceps really just adds a little bit incremental more compared to the other way around, which is the way we've been doing it.